welcome to Dragon Bytes, the paediatric podcast made in Wales, aimed at anyone interested in child health. I'm Stacey Harris, one of the founders of Dragon Bytes. Today we're a paediatric neurologist from the University Hospital of Wales, who's going to talk about epilepsy. Over to Assim.
I'm Assim Javaid, I'm one of the presenters for Dragon Bytes, and I've been joined today by one of our fantastic neurology consultants here at the University Hospital of Wales, Dr Anurag Saxena. Dr Anurag Saxena. Hello.
Hi, Assim. Thank you for inviting me to talk about things related to neurology. Is that what we're doing?
That's the general idea, yeah.
Okay.
I was hoping you'd be able to talk a bit about epilepsy. It's one of the things trainees struggle with a lot, both in practice and in the, if it's okay with you, just by outlining the basics, then maybe working from there in the future.
Okay.
All right.
Yeah, let's do that.
So the most basic of basic questions, what is epilepsy?
So this is a question which a lot of people struggle, and I don't think we have yet defined it. You can define it in various ways. I think let's start with the working or acceptable diagnosis, and that is usually a tendency to have seizures or fits, and the working seizures or fits, and the working diagnosis being that one should have at least 2 of such episodes which are unprovoked with fever or any other stress like sleep disturbance, etc. Every one of us have a epilepsy threshold at which once it is breached, we will have a seizure. If a person is made to not to go to sleep, as in one of the music festivals, I suppose, are stressed and consumption of alcohol is taking place along with it, and they are likely to have seizures at that point of time. But that does not mean that that person has epilepsy, because it was a stress-induced seizure. I just like to clarify what a seizure is at this point of time. Seizures are, in a literal sense, is to be seized by something, and that's how in classical literature people thought that you are seized by an external force, and because you lose control on your movements. So what we are talking about is a phenomena in which a person doesn't have control of, but is also related to a event in the brain. Okay, so which you can probably pick up on EEG.
So in summary, so an event in the brain that can be picked up leads to a sort of physical manifestation. And an individual has to have 2 or more of these, but in an unprovoked fashion. So can't have anything that's led to it.
Yes.
Okay.
So in children, most common kind of seizures you see are related to having febrile seizures. So they are not epilepsy. They can have multiple episodes of these, but they are classified as febrile seizures.
So as we're talking about epilepsy or seizure-like episodes in children, do you think there are any major differences between the types of epilepsy we may see in childhood compared to what we see in the adult population? Yes
and no. When I say yes, I think if you think about the classical description of seizures, as in a generalized seizure or a focal or partial seizures, they all have similar. There are some kind of seizures or epilepsy which are genetic in nature and present just in childhood, and few of them by name would be Dravet syndrome or Lennox-Gastaut syndrome.
I mean, I think it's probably a huge topic, a subtopic on its own. Perhaps we can come back to that at some future time.
So a take-home message is that I would say that epilepsy is, what you see is a symptom of a brain activity, and it depends on where and how the activity affects the brain that you get a partial seizure affecting one side, or get a partial seizure affecting one side, or a generalized seizure affecting both sides, or you have an absent seizure. Okay, it affects across the ages. It's just few of the genetic epilepsies are much more common in children than adults.
Okay.
Common in children than adults.
Okay. Can we talk a little bit more about what the underlying cause is in terms of this electrical activity? Or is this too complex an issue?
It's not complex, it's just not very well understood. So I would just say, as I explained to my work of electrical signals and the way various parts of brain or neurons talk to each other is by electric signals which pass from one neuron to the other. And for some reason, people or individuals with epilepsy have a short circuit. And the manifestation of these abnormal electric currents is that you have a seizure.
So how common is epilepsy?
So I think the estimate is around 3% of population will have epilepsy at such a varied presentation, in which some people will have 1 or 2 seizures and not have any seizures thereafter. Some people grow out of epilepsy, especially children, more likely than adults, whereas some will always have recurrent seizures. It is difficult to say for sure what is it is probably an accepted figure.
And given that it's probably 3%, let's say, of the population that have it, and they're not all having seizures all the time, we see an awful lot of seizure-like activity when on the wards and in our children's admissions unit. So presumably there are a lot of mimics and things that can look externally like they might be epilepsy, but aren't really. So is it all right to have a chat with you about what these other diagnoses might actually be?
So in order to delineate what is a mimic and what is epilepsy, you probably need to have some basic to recognize epileptic event in a child. You should all attend BPNA PET1 courses to do that. However, I think you are right that you need to know a lot of events or phenomena which are normal in children and they're not related to epilepsy. Unfortunately, we do not have a biomarker which will tell you that this event is epileptic and this is not. And it's just a clinical evaluation which will help you in these situations. And that is why epilepsy still remains a diagnostic challenge, which is unlikely to be replaced by AI in the future.
Right. So essentially, in the near future, there's no easy way out of the conundrum. We have to work on our clinical
There is
judgment.
no easy way, and there will always be a job of a person who works in
Pediatric neurology plugs. Right, so is it okay to talk about some of these
Yes.
these other possible diagnoses?
Yeah, so there is a huge list of epilepsy mimics which you can check online. There are publications and all those things. Briefly, we can look at some of them, and it is helpful to look at these from a age-wise distribution or time-wise distribution as to where exactly this event happened and the time of day. So what I'm trying to say is that an extensive and a good history taken to the event leading on to the actual episode is really important. It's not only the event which is there. I'm sure a lot of us would have been watching rugby, and there are lots of videos of rugby player concussed on the field because their head gets knocked and then they have a few twitches. Now that's not epilepsy, that's not a seizure. This is a phenomena which a lot of people do have in the context of concussion and acute brain injury, that they have some movements which may or may not be seizures at all. To be formal, I think one of the common things are syncope. Then second, for cardiac causes, which thankfully are not that common, but we always think about, even in pediatrics, is a long QT syndrome, hypertrophic cardiomyopathy, vascular migraines, transient ischemic attacks, strokes. Then metabolic causes like hypoglycemia or a movement disorder which can be confused as a seizure, such as dystonia or dyskinesia. Then you do have a non-epileptic attack disorder, which are thought thought to be psychogenic in origin, which especially in teenage population is quite common. However, one has to be really careful about making that diagnosis, and it is usually a combination of history, episodes itself. From the review of the episode itself, one of the biggest advancement we had in the last few years is an iPhone.
Right, yeah.
I think that was invented just for pediatric neurologists. Because these smartphones, and one of the first things we always ask the parents or the carers is to record the event, and then we can review it at a later date. So I think it is really important to have factual review of the episode itself to make that diagnosis. But the context of the event, such as what is happening in few days before, what is happening to the child itself, is it related to something which is happening in their lives, such as life stresses of change of school, breakups, etc., are also important. What were they doing at that point? Are they unwell? Were they well? Were they standing for a long time in the school assembly, etc.? When they did have this event, were they standing up, sitting down? Were they in PE session? All these will lead you to a eventual diagnosis. So a proper history of the event is important, as well as we need to know what were the conditions leading on to this.
That's very helpful, thank you. It's interesting you talking about the iPhone there, because often parents, even when we've asked them to in the children's admissions unit, is a really cheeky friend or passerby will record the event more so.
You do have to understand that most of the time, if you look and talk to the parents, they do feel that the child is going to die. So obviously they're not going to flip out their phone. So I do understand that, parents are mortified when they see their children having these episodes. I will just say two things to you. So first of all, the child is in front of you. If the child is not fitting and it's a paroxysmal event, it has passed. Okay, so you can reassure them that most of these seizures are brief. Vast majority of these seizures are less than 5 minutes. Okay, which is not going to cause them any long-term effects on their health or on their development. It is really important to review the event. You have to enable the parents to be able to take that recording, because if, for example, this child comes in for the first episode, you're not going to suddenly make a diagnosis, because it's a process rather than just a based on one attendance in A&E. So you will reassure them, you will give them these instructions, what happens, how do you do some first aid at that point of time. And I think part of that should also be, could you please take a video record for when they get reviewed again. Remember, you need 2 episodes to make a diagnosis of epilepsy. So in first episode they won't.
Yeah, exactly.
As I said, there is no biomarker for seizures or epilepsy, and the only way you can make a definite diagnosis is by history. You will probably not find anything wrong with children and examination also. Okay, but history is the most important point in making a diagnosis of epilepsy. And then people get worried about EEGs. Now EEG is great, but an EEG between 2 events of seizure, which we call as interictal seizure, EEG, is usually the yield of those kind of EEGs, standard EEGs, which is half an hour or so, is not that great, because your brain activity might revert back to normal. Get anything out of it, so you are then left with a normal EEG, and you think this might be an epilepsy but the EEG is normal. So does that mean it does not have seizures or epilepsy? And the problem is that the EEG might be discordant with the clinical right? So the diagnosis is still made on history and your interpretation of the event plus minus video evidence.
Sure.
EEG is done to confirm. It is not to make a diagnosis, it's to confirm a diagnosis. Okay? And it's helpful, so it's to confirm a diagnosis. Okay? And it's helpful to make a decision about maybe treatment choices, but not much more.
Right.
Okay? Then the scans, we say. Okay? So if there is focal onset seizures or any onset seizures or any manifestation, for example, when they wake up and they're not moving one of the sides, which leads you to believe that this was a focal seizure rather than a generalized seizure, then that's an indication of a scan. The question is what kind of scan? So CTs are quick looking at a bleed, a fracture, or a big lump. But they are not really good at looking at the brain itself, and sometimes you need an MR. But depending on where you work, it might be that access to MR is limited. It might be that access to MR is limited. And in that case, because there is a big anxiety over first episode of the seizure, you can always do a CT, and that might be a pragmatic choice. Examination wise, always look for neurocutaneous stigmata, so for example, or vascular anomalies in cases of Sturge-Weber syndrome, for example. So always look for that. Don't miss them, because that's a bedside diagnosis. And otherwise, as I said, in postictal state, you can think about focal child with a episode in a clinic. Most common finding is no finding.
So when these new children present to us, we tend to do a whole barrage of tests if it's the first time they're presenting. So presumably they're to rule out some of these other possible causes. So if I run through a couple of other possible causes, so if I run through a couple of them with you, I'm sure some of them will be obvious in answer. It'd be useful to hear your thoughts on them. So blood sugars normally pretty soon on the list, isn't it?
So sugars are quite good because so hypoglycemic seizures related to low glucose, they can either be an effect. Okay, so they are quite rare until it's in the context of a type 1 diabetes and insulin overdose. And in my experience, in the time when I was training, there were instances of insulin overdose, and these people with hypoglycemic seizures, true hypoglycemic seizures, never recover without rescue glucose. Okay, so I know there are lots of instances in which you have paramedics who test the glucose and it's low. You have to have a lab glucose which is low before anyone can say that is the cause of the episode. So it is helpful in the sense that it is something which you always do for any sick child, but in the context of epilepsy, again, it's an induced cause of epilepsy, then it's not epilepsy, the secondary cause. But yes, it is helpful.
We also do ECGs.
So ECG is quite helpful because you could have episodes which are related to prolonged QT syndrome. It's usually quite obvious if you look at a prolonged QT syndrome, ECG, that's that. But also it depends on you calculating the QT interval yourself. Do not rely on the machine. Then the other context of an ECG where ECG could be helpful is a heart block. So ECG is helpful in that case. So any unexplained fall or episode, then you need a ECG to do that. The other thing is in the context of a mimic like syncope, you do need a ECG anyway. So it's more in keeping with syncope rather than epilepsy. And that is what we are trying to rule out, because you can do something about that. And also which specialty to tap on.
so not to bother you with this one.
Yeah. Don't bother neurologists with syncope.
Fair enough. I think, and alongside that, there's also checking for electrolyte.
I think we do some of these investigations, but the yield of these investigations is often quite poor. Yet I think it is reassuring for a lot of people that these are normal.
Yeah.
The electrolyte related to an event such as a seizure could be calcium, magnesium, low sodium. Yes, and sometimes because it might actually give you a clue as to which way to investigate further.
Yeah.
Some of the brain events are in a sick child could be related to a low sodium because of a variety of other causes. Okay, so sodium, calcium, magnesium, variety of other causes. Okay, so sodium, calcium, magnesium are essential because they can give rise to a brain manifestation. Right?
Yeah. And finally, just going back to what you said about history being, the key element. I think there are a lot of seizure types I've seen where the history was the factor that helped us determine whether it was an actual seizure or whether this was another event. Yeah. So I'm just going to throw some possible causes of these episodes out at you, and what would you say would be the determining factors in the history that would lead you to one diagnosis or the other? So a common thing I've seen is
usually these are episodes in which children stop breathing, and they are kind of related to some brainstem event, usually preceded by a painful stimulus. You can have few twitches after the episode has started, and it can be quite frightening because the child can go pale or can go blue, and they do stop breathing, but there is unfortunately nothing much we can do as clinicians or as parents to change the course of that event. Thankfully, children grow.
Earlier, but then there are febrile seizures or febrile convulsions, however you want to term it.
Yes. So febrile convulsions are unique to children. Usually, I think between 1 to 5 years, can be a bit earlier also. These, which are in the context of a growing brain or developing brain, so you don't see them in adults. Majority of them are quite benign in the sense that you will have few of these episodes that do not affect your development and do not give rise to epilepsy in future, but you have to then make sure that these are simple febrile seizures, because then you come across atypical febrile seizures which long-term issues.
Right.
Okay. Now febrile seizures are a discussion on their own, actually. So I would probably think about doing a febrile seizure talk.
Fine, we'll do a separate febrile seizure, because they probably are. They're probably one the most common, the commonest.
They are the commonest.
Yeah, they're probably the most common, the commonest.
They are the commonest one. Yes. Yeah. No. But the other thing is, there are some genetic causes now.
Oh wow.
So genetic epilepsy and febrile seizure plus, and so that's why I'm saying.
So watch this space.
Yeah, watch this space. Yes, exactly. Yeah. So it's a quite interesting cause, because actually it is not part of the epilepsy as we see it, but it is one of the most common things you will see in CAU or A&E department. So we can discuss it very quickly, but these are kind of parasomnias we talk about. So most of the episodes which sleep awakening, you can have nightmares, you can have sleepwalking. All these episodes are brought on by parents, and then you have to decide whether these are related to seizures or not, because sleep also makes your brain likely to have fits and seizures. So I think, again, the history is important as to what happened, what time in the night did these happen. But these are quite benign, the three I mentioned initially, the nightmares, sleepwalking, sleep awakening. There are some other sleep-related problems such as narcolepsy, which is not epilepsy but a sleep disorder. Is not so benign. Okay. Very related to narcolepsy is cataplexy, which is loss of tone because of brought on by emotional causes such as laughing and joking. So there are videos of people laughing and then basically falling over, completely awake and with it, but they just can't control. It's a motor phenomena.
Sure.
Okay, but again, rare. Okay, so these are quite good to discuss, but you will probably never see them.
Yeah, but they're interesting cases, aren't they? And I think the last mention, because I think then we're going to be firmly heading into the realms of actual epilepsy syndromes then, is one that I only came across when I did the PET1 course, which is like self-gratification episodes in really young infants.
Yes, so it's very common and it starts very early, so it's not nothing to do with teenage.
Yeah.
And it starts very early, so it's not nothing to do with teenage.
Yeah. They were very young in the sample videos that we showed.
So they're young children who have these episodes of self-gratification, but the context is important. And if you have seen those videos in PET1 courses, they're usually always and either watching TV, usually in a high chair, and you can see that they are, if you can visualize, they are probably
rhythmically gesticulating
and lost in their own words. Okay, so they're watching a pie in the sky. Right. The other common context is in a car seat.
That was the video, I remember.
Yes.
The video was a car seat child.
So that's those are quite interesting and sometimes quite difficult actually. We have not discussed tics and
that's true, we haven't discussed it.
Which are quite common, tics, Tourette's and movement disorders, which are very common in children and can be confused with epilepsy. So I would have a look and attend a PET1 course.
Yeah.
But did you find that PET1 course interesting?
I thought it was really good. It was in Bridgend. This was 3 years ago. I think I went, so I probably need a bit of a refresher. But I thought it was really good.
It is quite good because I think one thing which we worry about in any of these episodes is that am I missing a seizure? And actually, what you realize is that in the whole churn of epilepsy and non-epileptic attacks, seizure is one of those episodes rather than the episode. We always worry about the worst case scenario, whereas there are other explanation of these things. So as you've said initially, you should always rule out other causes, and country is not going to kill you. And short episodes, self-limiting, which do not have long-term effect on health. So we can take your time.
Yeah, exactly. And plus, once the diagnosis is made, it has its own, unfortunately.
Discuss before you make a diagnosis and also after you make a diagnosis, how do you support the family, what is the effect on school, wider community. Driving
for the older kids.
For teenagers, yes, it's very important for them. Why am I different? Very important for them. Why am I different and have these things rather than my brother who doesn't, and other friends of mine, school trips, sleepovers,
swimming lessons.
Yeah. So all those things, how much do you want to supervise? You don't cotton wool, but you do want to put some kind of safety mechanisms in it. It's usually quite sensible measures, but making a diagnosis is not the end of it.
Yeah. I just wanted to say, so you mentioned PET1 a few times. I just wanted to say, so you mentioned PET1 a few times. Very well plugged. Are there any other resources that would be helpful for trainees who are interested in learning more about epilepsy and epilepsy syndromes?
Yes. So some of the websites we always ask our parents to look at is epilepsy.org, epilepsy.org.uk. Then children who we think are having syncope, they should be seeing the STARS website, which is the Syncope Trust and Reflex Anoxic Seizure website.
And what's the web address for that?
So web address is...
So the web address is heartrhythmalliance.org.uk/stars. Yeah, maybe just Google stars would be easier.
But Epilepsy Action is quite informative, and there is a section in professionals for professional help. And if you want to look at specific condition, they have articles written by eminent neurologists in that. So I would certainly recommend that. You can go and talk to epilepsy nurses in your hospital. They are quite a good source for education and for generally to the parents and children they see. So I think that will be a good learning exercise if you can spare the time. Some of the hospitals, not all, have a first seizure clinic, which is quite helpful because if you look at the outcome of first seizure clinic, most of the children who they see turn out not to have epilepsy. So that's also a learning point, as well as enables you to be sure that most likely you have to find another cause for these events. So I would encourage all the trainees to attend those epilepsy nurses as well as epilepsy first seizure clinics if you have that resource.
It'll be a while until your next until you get a chance to get onto a PET course. While getting ready to have this chat, there's a great article on the BMJ Practical Neurology by Dr. Phil Smith called Epilepsy Mimics, Borderland and Chameleons, and he happens to be one of the consultants here in Cardiff. But it was a very good article, though mainly more aimed at... He happens to be one of the consultants here in Cardiff, but it was a very good article, though mainly more aimed at adults than the paediatric population.
Yes, I think that we were looking at it as we were chatting, and he is a great teacher. You can learn a lot from him anyway, but I think it's a very exhaustive list of the mimics of epilepsy in this article. Obviously, he's not touched on the infantile causes, but I suppose we can certainly look at them at a later date. But to start with, this article is quite great.
Excellent. Well, thank you very much
for childhood epilepsy. The process of trying to make a diagnosis, taking the family through it, and treating them and trying to manage their epilepsy with the hope that they will probably grow out of it is quite interesting to me. And the fact that you have to is quite interesting to me. And the fact that you have to use your clinical skills rather than rely on a lab investigation to be sure about that is an added bonus.
Yeah. Though if you are a researcher and you came across the lab test that did it for us, you'd be in millions.
That will be fun.
Did it for us, you'd be in millions.
That will be fun. Yes. We can only try.
Yeah. Lovely. Thank you very much for your time, Dr. Saxena, and we look forward to hearing from you again.
Thank you, Anurag and Assim. So, how common is epilepsy? The epilepsy mimics, EEGs, CT scans or MRI scans. The importance of looking for neurocutaneous or vascular abnormalities. The tests involved around investigating epilepsy. Reflex anoxic attacks. Febrile convulsions, parasomnias and self-gratification. And on the website www.dragonbytespodcast.com, you'll find the links to the website they discussed. Thank you for listening to Dragon Bytes.